All right, friends, let's move in and talk about the third major group of injuries that we want to be able to identify and treat. We've said that's complications involving the airway. The first major problem we want to identify and treat is life-threatening bleeding. Shout out if you know the answer. If you see life-threatening arterial bleeding, you're going to treat that with a tourniquet. Right answer. Good job. Number two, the second group of injuries that kill people on the battlefield, chest injuries, particularly those that produce the complication known as a tension pneumothorax. If you know how to put a tourniquet on and you know how to recognize and treat a tension pneumothorax, you are going to save virtually everybody who has an injury who can be saved. In contradistinction to the civilian world of trauma, airway falls down to the last smallest group of injuries that kill people. To the best of our ability to measure, it's probably about 1% of modifiable deaths from battlefield wounds. What we're going to do in this block is we're going to talk just a little bit about airway anatomy to help things make sense. We're going to talk about some temporizing measures to maintain somebody's airway. We're going to talk about how to use the nasopharyngeal airway, and then we're going to talk about the recovery position. Who here sleeps on their side? You already know the recovery position. It's really that simple. Anatomy is our common language. It really does serve a purpose to help us understand what's going on. This image you've seen before. This is showing the upper airway anatomy. Again, how does air and oxygen get into our lungs? The air has to come in through the nose or the mouth. It has to make it past the tongue and the back of the throat, pass down through what's called the glottis, the level of the vocal cords, to make it into the lung. At our level of training, the things that we can intervene in is problems with the airway that affect air from getting in through the nose or through the mouth. Here's what I want you to appreciate about this image. I want you to look at the nose where the air goes in and the area we call the sinuses. The roof of your mouth, the hard part you feel when you stick your finger in the top of your mouth, is called the hard palate. The passageway of air from your nostrils back to your throat, that passageway is pretty much parallel to the roof of your mouth. Very important for what we're going to do to treat a problem of the upper airway with a nasopharyngeal airway. Where you pick boogers and where you scratch your brain is not the pathway that air takes to make it into your airway. That channel, that space, is really parallel to the roof of your mouth. And if you don't remember anything else from this section, remember this. When we're putting that nasopharyngeal airway in, it is going parallel to their hard palate, not up towards their brain. For an unconscious, or what we call a semi-conscious person, they're in a state of muscular relaxation. We've all heard of this euphemism of, quote, swallowing your tongue, end quote. But we all know that's just a euphemism, right? What actually happens is if you lay somebody who's unconscious or semi-conscious, meaning they have an altered level of consciousness, if you lay somebody like that on their back, their tongue will fall to the back of their airway and occlude that airway. That's pretty similar to what's happening when somebody has sleep apnea or they lay on their back and you hear them snoring. That's the air trying to exchange past the tongue sitting on the back of the throat. But in an unconscious or semi-conscious person, especially somebody who's maybe received narcotic medications for pain control because they've received an injury, that can quickly lead to occluding their airway, which will lead to death. If you can't get air in, you can't sustain life. There's a couple of temporizing maneuvers that we can do to open their airway. And notice I used the word temporizing, meaning it is not permanent. This is the head tilt chin lift or the jaw thrust. Nasopharyngeal airways are interventions that we can apply at our level of training as combat lifesavers to help protect somebody's airway. It's nothing fancier than a small rubber tube that we stick in their nose to keep their upper airway open. It's an extremely easy procedure, and there's nothing to overthink about it. Let's take a look at how we do that. The third major group of injuries where we have the ability to intervene and save somebody's life is when they have an airway occlusion. Most of that, as we know, is simply positional. Anytime we don't have to have a casualty laying on his back, it's best not to leave him that way. If he's conscious and can sit up, let him sit up if the tactical situation permits. Otherwise, we like to put people into what's called the recovery position. And again, if you sleep on your side, you already know what the recovery position is. However, if somebody has to be maintained on their back, there's a couple of maneuvers that we can use to help them maintain an open airway. Mike, do you want to take us through that?
Happily. Some of the most basic airway maneuvers that are performed on a daily basis in medical care are simple positioning. One that you may have heard before if you've taken any kind of CPR class is the head tilt chin lift. Basically, you maintain control of the chin and you tilt the head back. This is slightly exaggerated to give you a firm grasp of the concept of how we perform this maneuver. Basically, what you're doing internally is allowing a void between the hard palate and the tongue where air can flow into the lungs and lower airway. If you are concerned about C-spine injuries, which primarily statistics tell us in TCCC battlefield wound scenarios, we don't need to be concerned about spinal injury. This is a perfectly appropriate maneuver. But if you are concerned about C-spine injuries, another technique is the jaw thrust. With the person in an inline position, you grasp either side of the rear of their jaw and simply push forward. This can be fairly uncomfortable to the patient, but you need to remember that while it's uncomfortable to them, it is helping them to breathe better. Primarily, this is only going to be used on your semi-conscious or unconscious patients, though. Anything you'd like to add?
You're absolutely right. As far as the doctrine of TCCC, it doesn't have a lot of attention to C-spine injuries. They're actually not common injuries on the battlefield. Whereas in the civilian world, with motor vehicular trauma being the primary mechanism of injury, it's one of the things we have to spend a lot of time thinking about. The kind of thing that might raise your suspicion that the person has a C-spine injury would be that part of their injury mechanism involves a motor vehicle, that they've sustained some sort of injury at the level of the clavicles or above. In that case, it might be completely appropriate to consider that they have a C-spine injury. Otherwise, it seems to be fairly uncommon, and again, we don't spend a lot of time thinking about it. Both of these maneuvers are temporizing. It's not going to keep their airway open as long as you lay them on their back. What we can do to help maintain an open airway is this: placing a nasopharyngeal airway. This is nothing more complex than a small rubber tube. It has a flange on one end to keep you from pushing it in too far. It will travel through the sinuses to the back of the soft palate, and on most people, it will generally protrude low enough to keep the soft palate off the back of the throat. It generally will not be long enough on most people to keep their tongue from occluding the back of their airway. We use this on unconscious or what we describe as semi-conscious patients. Very few conscious patients tolerate this well, though it is essentially rated for use as well on conscious patients. By the time somebody wakes up and can reach up and pull this out of their nose, they're ready to have it taken out. How do we place it? It's very simple. This is packaged in a manner where it will easily go inside your IFAK. It is not sterile. It is clean. Your sinuses are not sterile. They are clean. It is not a sterile procedure. Likewise, if this outside container shows an expiration date that's passed, but overall the container is clean and doesn't have major cracks in it, I consider it acceptable to use. Even if there are small cracks in the packaging, because it only needs to be clean, I also consider it acceptable to use. The ones we package come with a small packet of KY jelly. Keep it on there and use it for lubing the nasopharyngeal airway. Don't remove it and use it for other purposes. However, if you have a nasopharyngeal airway and you don't have lubricant, almost anything will do, including the patient's saliva, to help it slide down the nasal passage. Placing the nasopharyngeal airway is extremely basic. One side has a bevel. Ideally, to assist this going down somebody's nose, if you could place the bevel side against the midline wall of the nose, known as the septum, which is Latin for wall, if you place the bevel against the septum, it will aid the airway going down the nasal passage. If it is possible for you to sense and feel the end or tip of the airway touching the back of the throat, if you can imagine and think about turning the bevel north towards the patient's head as you continue to advance it, the bevel will help guide it down through the airway, and that's where you want it to go. Again, when we looked at the image of the upper airway anatomy, we all appreciated that the nasal passage runs more or less parallel to the person's hard palate. The direction we're placing the nasal airway is parallel to the hard palate, not in an upward direction where we perceive their nasal passage to be. Application is fairly simple. Place some lubricant on the airway. If I'm going to place it from this side, I'm going to orient the bevel to where it is facing the septum. I'm going to drive it more or less straight down and back and apply it with a gentle twisting motion. When I reach the back of the throat, if I want to drive it with the bevel going down, I'll give it a slight turn as I continue to advance it. I'm going to bury it all the way to the flange. This flange is big enough that it is going to keep you from placing it too far. In my opinion, it is not necessary to tape this into place. If you have driven it as far as it will go up to the flange, it is unlikely to dislodge itself. If a person becomes conscious and wants to remove it, the tape will not prevent them from removing it. If I am placing the airway to the best of my ability and I encounter resistance, do not force the airway. Some people naturally have one side of their nose that doesn't suck air as well as the other side. I am one of those people. If that is the case and you encounter resistance, remove the airway, go to the opposite nostril, and attempt to pass it on that side. Usually you will have success on at least one side because most people have at least one nostril that allows them to breathe well. Sometimes there's question about sizing of a nasopharyngeal airway. People who are familiar with hard airways like J-tubes know that you have to size them appropriate to the patient. One of the advantages of the nasopharyngeal airway and why we use it in TCCC is that it is almost universal. This is a very common airway adjunct that we use in post-anesthesia care units in hospitals everywhere to help in the recovery of semi-conscious patients. Disregarding pediatric patients, guess how many sizes of nasopharyngeal airways we carry at my hospital? 1. Most people who have opined that they've had difficulty passing a nasopharyngeal airway on themselves or on a partner when they've tried to demonstrate the use of this have failed because they're not placing the airway parallel to the hard palate, and they assume it is a size issue. I can assure you that in almost 15 years of experience with these airways, I've never encountered a person on whom I could not pass a nasopharyngeal airway, regardless of the size of the airway, regardless of the size of the patient. At this point, where we've successfully protected the patient's airway with an airway maneuver, where we've helped protect their airway further by placing a nasopharyngeal airway, we're not done. We want to place this person into the recovery position to further protect their airway. It's the only position we want to leave an unconscious or semi-conscious patient in. Let's take a look at how you can place an unconscious person safely and easily into the recovery position. We want to demonstrate the recovery position for you. This is how we want to place and leave an unconscious or semi-conscious patient to protect their airway. If you leave them laying supine on their back, they're going to occlude their airway, and even a nasopharyngeal airway won't stop that from happening. How we get someone into the recovery position is essentially we're assisting them getting into a side-lying sleeping position. Here's how you do it. Take the near side hand, place it under their head. This will protect their head. This will also maintain some cervical spine alignment. Take their opposite side arm and place it across their chest. Take their opposite side leg, bend it, and try and tuck the top of that foot just behind the near side knee. From here, grab their hip, grab their shoulder, and bring them to you. To help them stay in this position, take their downside leg and bend it slightly. Now what happens, their upside thigh is about 90 degrees to their body, their knee will touch the ground, and tripod, their other arm can stay across their chest. It will also help them to maintain this position. Now, if the person has secretions, if they have to vomit, they're going to do all of that in front of them, and it's not going to go down their airway and cause them to aspirate. Their tongue and their jaw is naturally going to fall forward with gravity, and this helps the person protect their airway. The back of his foot's tucked into his knee. This knee is bent slightly. His thigh's at 90 degrees to his body. His knee is contacting the ground. His upside arm is across his chest. He's in a position where if he needs to vomit, he'll do that in front of himself and it won't go back down his airway. This is how you want to position an unconscious or semi-conscious patient.